we're missing several others. So if I haven't called your name as a board member, just please let us know if you're on the line. Bless you.
I covered it.
Have you seen those boards that they have that people are making? It's like a whiteboard with everybody's name that's in the office. And they're doing tick marks. That's how many times each one has it.
Oh, that would make me calm.
I would take that and smash it on the desk of whoever came up with it.
So we're just missing a few more.
Chelsea, are you on the phone?
Ronnie called into the Leadership Council meeting, so I'm assuming that she would call into this.
Can you hear me?
Missing.
It's Chelsea.
Oh, hi, Chelsea.
Can you tell us who all is the meeting, please?
Can I what?
Can you tell us who accepted the board meeting for today?
It looks like Kat just got on as well.
Hey guys, yep, Kat's here.
Yeah.
Yeah.
I think they're trying to talk. There's just a communication issue.
I'm looking a second. So we had Kendra, Loanne, Dan. Here, I'll send you the list.
We just need one more. And if Loanne has accepted the invitation, I would assume that she's going to call in.
Yeah, it looks like Ronnie accepted it as well. Loanne, Susan.
Are we taking roll call yet?
We have a list.
We've not really taken roll call yet, so we think that we're still a couple short yet, so it's okay with me if we give them a couple of more minutes. I don't know about the rest of y'all, but kind of some of those of us who are working in hospitals are up to our ears in what used to be alligators, but it's gotten way worse than that. So we may. I used to have a priest that I enjoyed very, very much. He had a patented lightning mass we could get done in 35 minutes. We might have a Brian Gibbons lightning GCACH board meeting if we have to. I don't think it's 35 minutes.
So Brian, it looks like we have Ronnie on the line. So if we could probably get started, and if there anybody else that joins us, that would be a bonus.
Okay.
We're thinking that Loanne will call in.
Are you close
But
to
otherwise,
quorum?
we have
Muted.
Dana, Rhonda, Dan, Brian, Kat, Kendra, and Ronnie.
Okay, so it sounds like you're at 8 or 9, right?
I think
Yeah,
Luann.
Oh, did Loanne
Okay.
just call in?
Okay,
Yep.
so why don't we
Perfect.
start out with a, are you ready?
Yes.
We can go ahead and call this meeting to order then. So why don't we allow me to welcome everybody, remind you to kind of use your button. Do we want to? You just kind of did a quickie roll call, right? I mean, are we good to go with that? We want to spin all the way around and do the full introductions because that's on the phones. It's going to be a mess.
Okay, so I can just tell you who's there. I think we have all the staff that's engaged right now. Your staff, and we have a new staff member, Laurel Avila, who joined us on Monday. So welcome. Laurel is a new practice transformation navigator who comes to us from Lourdes and is a nurse. And so we're so excited to have her on board.
Okay, that's great. Congratulations. I want to thank everybody for taking the time. I know these are kind of trying times, taking a couple of minutes to, not drive down to the ACH office or the United Way where we're all sitting there giving each other COVID. Makes things a little bit more challenging, but I am grateful because I have immunocompromised kids and I do not want to be bringing that stuff home. So I think these are going to be, we talk about it here at the hospital. It sort of feels like kind of a paradigm shift is going to come out of this, much like the September 11th stuff. Maybe not as bad, but you still can't just walk on the airplane without having to go through a whole lot of stuff. So I have a feeling we're going to have a lot of people telecommuting on the go forward. We're going to find some good things out about how we can get stuff done that didn't necessarily take having people in the same places, though I would many times rather we were able to do that right now. But I think we'll probably see more of this kind of work. So, but I do appreciate you guys taking the time to get on the phone and still get the business done. So with that said, we'll remind everybody about our conflict of interest policies. We try not to, vote on things with conflicts of interest. We are careful of the self-dealing transactions. Please be advised of that. I think. What else can I say? I think Becky, you sent out a number of things to sign over the last couple of days, right? We had policy and a bylaws, right? That stuff all got out to everybody?
Yes, it did. And actually, Chelsea sent that stuff out. The DocuSign account's just in my name. So it wasn't actually me, but yes, it got sent out.
Okay. I can tell you, I just signed those things off. I had a hard time signing off on the policy. I haven't been able to pull that off. I might have to reach out to you, but I would imagine some folks are maybe having a little trouble with that, but that's not a big deal. Okay, so has anybody had an opportunity to review the minutes of the prior board meeting? And if so, I would appreciate a motion to accept.
We accept the minutes as written.
Okay, any second?
A second, Sandra.
Sandra, so I've got a motion from from Ronnie, and a second from Sandra, correct?
Kendra.
Kendra.
Gotcha. Any discussion? Okay. All those in favor, please say aye. Aye?
Aye.
Aye.
Aye. Aye.
Aye.
Aye.
Any opposed? Thank you very much. All right. So what do we got next? What do you got?
COVID-19.
I got to get back to my agenda. Oh, here we are. GCACH reports and updates. We're going to start out with Carol with your COVID-19 discussion, right?
Yes, so this week all the ACH leaders have been getting together, the program managers, all trying to share information out, trying to figure out what we should be doing in this space. So we have two things that we're bringing in front of you today. One is just a wonderful piece of work that Lauren did to compile all the resources that are out in our community, or that are out in the state, regional, nationally, really, in terms of resources. Do you want to bring up that list? Mm-hmm. And so this is on our website. it lists some really important detailed information about how to access the codes for telehealth and mental health, information from 211, alien emergency medical, just a whole list of resources that we've been receiving from all of our partners across the state, Department of Health, GCACH, Healthcare Authority, our MCO partners. The first one, the 1135 waiver request, is something that the state of Washington is requesting from the federal government in order to be able to use, again, Medicaid dollars in innovative ways. They're waiving certain licensure requirements in order to increase capacity in mental and behavioral health. So just if there are any resources that we were missing from this list, Lauren has did a wonderful job compiling it. At the top, we have a couple of indicators that she's been trying to track on a daily basis. And these are positive and confirmed cases of COVID-19 and some death statistics as well. So we tried to tell more of a complete story at the encouragement of Laurel in terms of here's what's coming, but there's some bright spots in terms of the number of cases that are negative compared to the number of positives. So if you guys have any questions about that, I think we're going to try to just do all of these reports very quickly so we can get everybody back to work.
Yep, I think that's good. Thank you. I think you're right. We've had a lot more negative than positive. So that's good, though doesn't mean that they're not all going to convert later.
Yeah. Any questions?
Oh, this is good. I like that it's here. And, you know, the Washington State Hospital Association asked, and I mean, I can't even tell you how many conference calls we've been on in the last 10 days about some of the roles and some of the information coming out of the ACHs. I think this is valuable information. Have you shared any of this with the Washington State Hospital Associations? Would you be interested in sharing it with the WSHA? Just from an information standpoint, resource utilizations and whatnot?
We will definitely send it to them, Brian. Should I send that to Claudia Sanders?
You can send it to Claudia, or because they've just pulled Claudia back out of retirement, like today.
Okay.
Or you can push it to Cassie, or you can push it to Cassie Sauer, who is the president and CEO over there.
And Brian, Brian and Carol, the Sentinel Network is looking at revising their survey and getting it out to address workforce shifts and trying to figure out utilizing trusted leaders to try to determine how to best access almost in real time changes in workforce demand and needs, and looking for suggestions about who to make contact with, even though this is a current emergent situation. So just FYI, so the Sentinel Network is going to be sending out, and ACHs have been really good with that, and just looking at workforce shifts across the board, and looking at how then other partner organizations can help support with those, kind of mitigate the challenges around workforce.
Yeah, that's really good too, because we're finding that in many cases, one of the things that we are worried about as a hospital is, and frankly, in our provider settings with the physician providers is, once somebody goes down in the clinic, that they really have some significant implications. And at the hospital level, and once you lose a nurse, that or if you've got this big surge capacity, maybe what we got to start doing is thinking about team nursing approaches and nursing extenders. So there's a lot of work being done there. So with that said, let's move on. That's a very good piece of work there. And if you wouldn't mind sharing that with Cassie or Claudia, that would be great.
Yeah, Lauren and Diane did a great job of compiling this list. They have our deepest thanks.
Yeah, that looks really good.
So the other thing that we talked about was what could we do immediately in terms of telehealth. That seems to be a strong focus on our transformation alignment call on Monday, with the potential of and the need to actually deliver medicine in new ways through telehealth and behavioral health and mental health. So we put together a really quick survey. We've had 31 people respond to it. The initial list was sent to our 83 cohort or our 83 sites. We expanded that this morning during the Leadership Council, but we've heard from 31 organizations in terms of whether or not they're currently offering telehealth or considering offering telehealth in the near future. So on the screen, you'll see the results of the Survey Monkey. So we have about 68% of that are currently offering or thinking of offering telehealth in the near future. Yep. And then the next question was, what kind of assistance do you need in purchasing equipment for telehealth? If so, what kind of resources do you need? So we're seeing a strong need for purchasing a laptop, webcams, expanding internet bandwidth, and then there are a host of other responses that Lauren's bringing up. Need help with all of these things, software, technological aspects of delivering this. Some don't know exactly what they need, but they just need assistance. So what this led us to believe is that there is a role for the ACH to play in helping purchase some of this equipment. The next question was, do you have the information you need to bill for telehealth? Kind of split between yes, no, and other. So another reason that we have these great resources that Lauren put out.
Mm-hmm.
So some of the billing codes actually in that document that Lauren just presented, there's 2 documents in that list that talk about billing and coding resources for telehealth and behavioral health. So that's part of that resource list that we have. And then just kind of an afterthought, if you've implemented telehealth services, would you be willing to present during a learning collaborative? So one of the ideas is if people are needing that technical assistance that we talked about in the earlier question, we do have people that are doing this right now that could lead our peers through it. And then any other information that they would like to provide, some comments there that you can see. Getting approval might be a problem. Still waiting for guidance on telephonic visits in lieu of face-to-face. Excited to use the Zoom opportunity, and Diane can speak a little bit about that. Yeah. Again, have the technology but need training. So we're seeing a true role for the ACH to play in terms of getting information out and providing technical support, especially in billing and coding. Diane, did you want to talk about the Zoom line?
Sure. So the Healthcare Authority recognizes that this is a new area for behavioral health providers, and so providing telehealth. And so they are going to provide Zoom accounts to, they're going to start out with the rural areas, but then bring it back to hopefully provide it for everyone. But they are HIPAA compliant and 42 CFR compliant. So we're excited. As soon as we get the information, we'll distribute it out to the providers. Like Carol said, they're having a webinar every Tuesday and are continuing to provide guidance in this area. There's a modifier in the billing code. There's a modifier for disaster, and so they want everybody to use those billing codes that are in the file. That one of the information that Lauren has, and I had also sent it out to the behavioral health providers, but they also want to have them use the modifier at all times. That way, they can kind of track how many claims are actually done during this time of the crisis.
Right. I've heard, I think I've seen, this is Brian, I think I have seen code for telephonic screening too. That is.
Yes, they do have that on there, and they also have just also given a group and individual sessions, numbers as well. And so I think this is an area that our behavioral health haven't been able to utilize, and since the president has loosened the ban kind of on the way that behavioral health is given, more of the face-to-face things. It's given them the opportunity to use the telehealth at this time. So I think this is really great.
I do too, and I think this is going to be one of those paradigm shifting elements. You're going to start to see some of these rules get loosened up a little bit. We're seeing unprecedented releases of the leash, if you will, to get through this. And I think I think at the end of the day, I don't think it's going to go back to as stringent. I think we're going to find some things that work pretty well, and I think you're going to start to see some of those things stay in place. So that's actually pretty good. I mean, those are the silver linings in this mess. But we are seeing the telephonic and the telehealth opportunities, and frankly, we're finding that we can do a screening assessment over the telephone and get a patient to come in, who maybe does meet criteria, and then bring them in, do a drive-by, if you will, registration test or specimen collection, and then move that test off without exposing or compromising staff, and that's been a big deal. So there's a lot of work being done in that across the board. You're seeing that in the behavioral health side too. So there's a lot. Again, there's a lot happening here very, very rapidly. The biggest challenge is that it keeps changing.
This is Dana. And the healthcare authority for the Zoom option, they said that they would send out an application process for providers to apply for it. And I looked on their website and I haven't seen it yet. If you have access to it, or if you do get it, would you send that out to everybody as well?
Yes, as soon as I get that, I can send it out. And I've been bugging Teresa, Healthcare Authority, about it every day. She did tell me that she will send it as soon as she gets it. But she also said there's a couple other, I can send you, Dana, there's a couple other sites that are HIPAA compliant that she said that can be used as well. So I can send that information out to the providers as well.
Okay, yeah, that'd be really helpful. Thank you. And the state submitting the waiver for behavioral health WACs that removes the in-person has been really, it's really helped us to be able to make connection with those patients, because this is such a high anxiety time. So it's been very beneficial for us to be able to make those telephone contacts and eventually move to more video contacts.
Yep.
Yeah, the president also was saying that he's really, they can use Skype. He basically said you could use any kind of communication. It doesn't have to be, he's removing some of those HIPAA compliant rules in order to be able for patients to be able to be seen and get the help that they need without having any constraints.
Yeah. Okay, that's excellent. Thank you for that.
So Brian, we just wanted to demonstrate. So this is one of the resources that talks about the codes for telephone evaluations and services. So that's part of that list. Just the other thing that we wanted to alert the board to, in the event that you're feeling extra philanthropic today, is some of the other ACHs have identified needs in the community that can't be paid for immediately unless it's coming through their ACH. So we just wanted to let the board know that we did get a pay for performance bonus last year. It's worth $400,000. We've already received $300,000 of that, and the next $100,000 is going to come in April. So this is the letter from the independent assessor, so you know I'm not lying. And then if you could go to the dashboard, the EPI portal dashboard, we'll even show you what that looks like in terms of our dashboard. so that line right there confirms that we have that $300,000, and we have not earmarked that for anything yet. We have not factored that into our funds flow for provider incentive payments and for any of the other programs that we've laid out. So if the board wanted to allow the staff to find ways to use this money to address the needs that were identified in that earlier slide, that would enable us to act quickly to our providers in need.
Okay. Do you want to make I mean, I appreciate that's not a bad idea. Do you, how do you want to advance recommendations? Do you just want a blanket approval? What do you want?
I think that most helpful would be just authorizing staff to use these funds in a responsible manner to meet the needs of our partners and stakeholders in our communities to address the COVID-19 epidemic.
Okay.
We can get information back.
Say that again?
Sorry, Brian, I cut you off. We can be accountable to the board about bringing information back about the use of the funds.
Of course. I would be amenable to accepting that recommendation. I would like it to require Carol's approval, right? I mean, obviously it requires Carol's approval. I'm saying the obvious, but you just kind of got to sometimes state the obvious. So before those decisions get made, you get to be the final say on them, right? So
okay, I can do.
So Brian, I could make a motion to allow Carol to use up to $300,000 to develop a plan to address the COVID pandemic with the use of specifically to address telemedicine needs. Or is that what you were referring to, Carol? To develop a plan for helping programs develop their telemedicine capacity?
Was it to develop a plan or to start implementing?
I think it.
Well, to develop the capacity and implement.
Yeah. And did you have it limited to telemedicine, Carol?
That's what the motion was. That's what I thought she was asking.
Yeah.
Well, I'm concerned that we would limit it to telemedicine, and then all of a sudden we find out that there's some other great need. I'm really thinking about skilled nursing facilities, quite honest, Rhonda.
Okay.
And well, that we are limited by just the telemedicine. So I think if there's any big thing, we'll send it out to the board, but I'm not necessarily.
Okay, well, let me restate my motion. I would make a motion to authorize Carol to develop a plan to address the COVID-related issues of the region.
Okay. May I have a second?
Second, this is Dan.
Ladies and gentlemen, do we have any additional discussion?
This is Sandra. I just have a question. So the motion is for a plan, not to actually start releasing funds, but to develop a plan over the next 30 days until our next board meeting, where then we can get a better understanding of what's needed and where and why. Is that correct?
No, that wasn't my intent, Sandra. Sorry, because I think if the plan is developed, I think she should have the authorization to deploy it.
Yes,
okay.
I agree.
Could you restate the motion then?
Sure. Sorry, I think we're all a little sleep deprived, or some of us are.
Yeah,
I
sorry.
make a motion. That's okay. I'm glad you caught it. I make a motion to authorize Carol to spend up to develop a plan and implement a plan. Develop and implement a plan to spend up to $300,000 for the purposes of addressing the COVID-related issues in our region.
My second stands.
Again, we have a motion from Rhonda and a second from Dan to this motion. Is there any additional conversation? Which would, allowing Carol to spend up to $300,000 after, developing a plan and executing that plan to deploy up to $300,000 to support COVID-related matters within the region.
This is Ronnie.
Hi, Ronnie.
Hi. Since I'm not getting all of the information that is being talked about because it's like cutting in and cutting out, but I'm trying to understand it, so I'm just wanting to clarify that I understand. The money that's being used was sent to us through the through the system, and that money can be used for whatever we design it for. And we're choosing to let Carol utilize that money for the COVID-19 needs.
I understand that is correct. I do not believe these dollars have been earmarked otherwise. Is that correct?
Correct.
Okay.
All right. Then when you're ready, I'm saying yay.
Is there any other conversation to have on this matter? Hearing none, I would call the question. So those in favor of this motion, please signify by saying aye.
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 Any opposed? Hearing none, this motion carries unanimously. Congratulations, Carol.
Thank you, board.
Okay. So the next matter on here is the GCACH report. Thank you for your COVID report. That's very, very good.
We're going to do really brief and sassies on each one of these articles. I'll summarize in a minute that you guys approved the $10,000 for the tribal wellness clinic for the Yakama Nation last month. That check was delivered. That's a picture of kind of the surprise party at the end of the check. I wasn't aware that they were going to do that. So those funds, I'm sure, will be very, very much appreciated.
Yep, that was good.
This next one, I would actually like to put this off as we've got an action item to talk about the behavioral health internship program SBAR and analysis, and we should be covering about those talking points at that time.
Okay.
Yes, and we recently approved $5,000 to go to Kittitas County Health Network for them to bring in a trainer to help facilitate strategic planning for them to continue doing the work to move forward. And this is exactly this is a really good reason why we created this fund for the local health improvement networks to take advantage and bring some additional capacity, some additional training for them to continue to do their work. So just that's again to all the limbs to start looking into this money to bring in trainers or to send people to trainings.
Okay.
Right, to do all money.
I've got the Washington.
Becky.
Okay, so next is the portal report. Just real quick, we changed it up a little bit, and so this report is really focusing on cohort 1, 2, and 3, showing how much money that we have given since the start of each cohort. So remember, they each started at different times, so that's why cohort 1 has the most. Cohort 3 got a lot of payments this year, and there was a lot of payments made to them this week that's not reflected on this report. So, but this report's showing over $15 million that we have given to the providers for their hard work on practice transformation. So congratulations to all of you.
Very good. Thank you.
Okay, and the next one is on the 26th of February, Lauren and I went to Yakima. Minerva Pardo, she's a Yakima community member, and she works for the West Dallas School District, and she's also part of the task force on the community resilience campaign. Both of us were recorded a little segment with Univision, a Spanish television that reaches the Tri-Cities as well. So we were there to promote the campaign and to invite people to participate and to go to the training, which is now canceled on the 28th. But, also, it's not here, but on the 10th of March, I also went to Yakima, and we were interviewed by KIT, AM Talk Show Radio in Yakima, Mary, Virginia, with ESP 105 joined me in that interview, and also at the Spanish radio station 96.9 Bustos Media radio station, and on that one Minerva Pardo again joined me for that interview, and they all went very, very well.
Good.
Oh, and yeah. Okay, and so the community resilience campaign is continuing to evolve. It's doing better and better. We get tinkered with some things. One problem we had initially was that we were not getting a whole lot of clicks on Google searches. When people search, we were not popping up, so people were not clicking on our ad. But we changed some search words. We changed some search words to be more ACES words. The search words we had there were pretty general, so we switched some of them to be pretty much examples of specific ACES. So that generated some good numbers. It went from 0% to 11%, and the average for this type of campaigns is 3.8%. Also, the YouTube videos, we had, and it's a lot more by now, I bet, we had 501 views in English, and about 91% of them, those views were viewed after 91% of the entire video, which is really good. We had 219 views in Spanish, and 89%, the average completion of the video was 89%. So 50 or 60% is considered average for this kind of stuff, and we ended up at 70%, which is considered excellent. And like I mentioned earlier, we already had 2 English trainings on the neuroscience and trauma informed. We had about 60 attendees for the 2 trainings, and we had to cancel the Spanish one for March 28th, which is sad. But we didn't cancel. We're going to postpone it. We're going to find a future date for that one. So, and I think that's it for me.
Okay, very good. Thank you.
So this one is mine, and we want to highlight Cadillac Regional Medical Center because they had a decrease in their avoidable ED visits. That's what AED stands for. And that's something they have been working on with practice transformation. As all of you know, it's included in milestone 6. As well as it was a part of their risk stratification to target patients who had avoidable ED visits. I talked with Deborah, who's their population health coordinator, day before yesterday, and she's like, my numbers are crazy because of coronavirus, so that's done now. So we'll see a spike. But yeah, that's an article.
Okay.
And I'm next. So I wanted to highlight Chaplaincy Behavioral Health. Chaplaincy Healthcare Behavioral Health, they've actually, in this article I mentioned that they're in the process of identifying an EHR vendor, but they have already identified that EHR vendor. And last time I spoke with them, they were about to sign the contract. One of the questions I asked them is, hey, did you guys make sure that it was that EHR is ONC certified? Since that's one of the requirements in milestone 8, that the EHRs that are being purchased with GCACH money is ONC certified, and then they open their wide open, like, oh, well, what is that? So I told them more, and then they contact them. So it is ONC certified, and they were in line to implement that software within the next few weeks. But given that the COVID-19 outbreak, then I don't know what their timeline is for that now, but they are in the process of getting that EHR.
Very good.
For the Learning Collaborative, we went ahead and canceled. Yeah, I'm going to go ahead. Can you hear me?
Yep.
Okay. So we canceled March's Learning Collaborative and we moved it to August. So she will be coming in on August 6th. And instead of doing 2, one for the community and one for the providers, we're going to do it all in one. Then June 5th, we have Elizabeth Pittman coming to talk about the HIPAA policy changes. and she'll also talk about some of the 42 CFR. And then July, we're going to do shared care plans, and actually Sam Wardell is going to be the one who's in charge of that one. And then in September, we will also have Sam be presenting to us on how to maximize Medicaid reimbursement and value-based payments. And then in December, we're going to have one on cultural sensitivity and cultural competency. And Carol and I are working on that to try. We think we have a presenter. I'm not sure if Carol wants to kind of bring that up, but we're hoping to reach out to a person that we that she read a book on, and so Carol and I are going to be working on getting that speaker for that.
Right. I think Carol and I have actually spoken on this a little bit, and you're welcome to share if you wish.
Well, I haven't talked to Dr. Alford yet, Brian, so we're still developing a plan to have her be a keynote, but I was also talking to Maxine Janis yesterday, so I think this will be a very exciting presentation for everyone.
Yeah, I think so too, and I'm sure she'll be supportive. I'll help you with that, of course.
Thank you.
Okay. Excellent. So thank you guys. Oh, you got more. Keep going.
This is Sam.
Yep.
Sam?
Yep, go ahead, Sam. Sam?
Is she on?
She might be on mute, but this is a picture. Now you can see Laurel virtually. This is Laurel, our latest. Oh, there you go. There you go. Go ahead, Sam.
Yes. Hi, this is Laurel, and she has actually came to us from Lourdes. We're very fortunate to have Laurel. She comes with a background of an RN, and we're very fortunate to bring her skill set to our table, as I'm an RN as well, but she brings a lot of hospital experience and a lot of clinical setting as well as student setting. So we're very fortunate to welcome Laurel to our team.
Excellent. It's very exciting. Thank you.
Yes.
Okay. Diane, I think you
We already talked about
right?
this, but yeah, you can move on.
So this next article is just about the annual Beyond Paper Tigers conference, and it directly relates to our community resilience campaign. So we're really excited to be sponsoring this event. I included the dates of June 24th and June 25th. It will be in Spokane, and if you're interested in registering, you can visit the website at the bottom of the article.
Awesome. Thank you. All right. You have another piece on there? What comes after there? So, go ahead.
That would be Sam.
Okay. No, let's go to let's see, let me come back to that last piece. You're fine. You don't need to switch pages. What do you guys, obviously we have this very intense effort to move people out of the office, get them working from home. Have you all deployed that to your satisfaction at the GCACH office?
Funny that you would ask that, Brian, because we have a telework, we have revised our telework policy, but yes, it's optional to come in and work in the office or at home for all GCACH.
Excellent. I will tell you some of the things that we've done here at the hospital. Of course, I've got a lot of people running around all the time. Pretty much if you're not taking care of patients, and unfortunately not an executive, because frankly, I think, I got to come to work. But we're trying to push as many folks as we possibly can out. And we are finding that to be an effective solution. We have taken all of our medical staff meetings, and they're all telephonic. We try very, very hard not to have groups of people in the same room. because man, I can't even imagine what happens. We're kind of operating under the assumption that everybody's going to get it until we are told that everybody's not going to get it. And so the only thing that you've got left is to change the timing of those exposures. And so that's kind of how we're working it from the hospital side, because if we start losing providers, we're going to have a big, big problem. And so you might think about it that way as well, even just limiting exposure. If you've got to have people who come to work, maybe they come to work 3 days a week instead of 5, and they work from home 2 days a week or something like that to at least reduce the exposures. And so we're seeing lots of good ideas with that too. So I think that's good work, and I'm glad that you guys are working to stay safe over in your offices. All right. So the next item that we've got is the WRHC update, right, Sam?
Yes, that's correct, Brian. Just to piggyback off of what you said, I just had a meeting with them yesterday, and we are changing some dates in regards to the Washington Rural Health Hospital Association in regards to trying to do a steering committee update as well as a board meeting update, and trying to do that teleconference. We're having a couple of issues with just meeting dates, of course, with the coronavirus. And then also our original agreement was 4 in-person meetings for the different partnering providers for the 11 organizations. And we are in the midst of rescheduling that and trying to do 1 learning collaborative. And we originally thought that we could do the teleconference for the May, and of course that was canceled. And then June, we thought that maybe they could be able to attend that. So we're in the midst of trying to schedule that one as well. So it's really all tentative right now.
Okay. That's fine. All right. So that's not an action item.
Unmuted.
Anything else to share with that?
I do not.
Okay. Let's thank you very much.
Welcome.
Chelsea, you are up next with the 360s.
Yes, can you hear me?
Yes.
All right, so we are about to have some 360-degree assessments conducted for staff. For those unfamiliar, 360 assessments are evaluations of an individual that consider feedback from their peers, their superiors, external stakeholders, etc. These assessments are an activity to help us successfully grow and evolve, both as individuals and as an organization in a holistic way. So this will be conducted by an external consultant in the near future. And so board members should have received an email or a note recently stating that we are soliciting some participation. And if you would like to participate, to let me know or fill out that survey. You would be essentially reviewing Carol, and so then Carol's reviewing our directors and so forth. So if there's any questions, please let me know.
Okay, very good. I remember seeing that come across, and I did not do anything with it. I apologize.
Thank you for your sobering honesty.
There's a lot of stuff.
Of the due date?
Yeah.
Our deadline
Chelsea, can you remind them of the due date?
Sure. So our deadline for responses to participate is tomorrow by close of business. So I will send a reminder out tomorrow morning because I know everyone has a lot going on. But yeah, so we'd like to have all those participants identified by tomorrow.
Okay. Well, you better make sure that I didn't do something with it. Maybe I did. All right. So thank you for that. Next update, Becky.
Oh, this is exciting. Tri-State did sign their contract after all we went through with it last month. So that's my update. Yay.
Yeah. Okay, good. That's great. Good letter though, right?
I'm sorry, what?
It was a good letter though, right?
It was a great letter.
Yeah. Okay.
Martha Landman and Jack Davies were instrumental in getting that signed. So I thank them both.
Excellent. It's very good work. Okay, the next item we got on here is the cohort 3 tracker.
Muted.
Martine and Jenna.
And I can present on that. So this is the tracker for the 3rd cohort of practice transformation. And there's some lines on here that are blank but have been, those line items have been submitted. For example, the contract with Tri-State, that one's blank, but it's been signed, and the proposed budget for YNHS and Walla Walla Clinic, both have been submitted. So we just left out those dates, but those have been submitted. Given, that there's the COVID-19 outbreak right now, we have actually decided as a group to extend that deadline for the first quarter of 2020 for the workbook. So instead of being on the 15th, we're extending that deadline to the 29th to give our providers a little bit more time to gather their data, since we know, everybody's really busy right now. So we've extended that date to the 29th.
Okay. I appreciate you doing that. I was actually going to make that recommendation. Judging from, I think the state is gonna get hammered in different times. And so I think you may see people in the further reaches of Eastern Washington getting in COVID trouble later than the guys in Central Washington, than the guys in Western Washington. So I think you may see you may need to, kind of keep an eye on how that thing's moving around, because I think that will impact people's ability. This work is going to fall off of the top of the radar and maybe move down a notch or two. So please be, you're probably going to want to be a little bit fluid with some of these over the next couple of months.
Yeah, we're being considerate of that. So we're also concerned and take that into consideration.
Yeah. Okay. I know you are. I think that's important. All right. I appreciate that. Thank you all for the ACH reports. Do you all have anything else that you want to share before we get into some of these action item comments?
I would like to share.
Go ahead, Carol.
I think Jenna has something she would like to share.
Uh-oh.
That's not a fun introduction, Brian. So my news is I let Sam know and Carol know and the staff, but I will be leaving Greater Columbia ACH, not because I don't love my job and my coworkers, but because I got an opportunity to move closer to home, actually at home, back in Georgia and Atlanta, to be with my family. And so I'm very excited about that. I recently went home last November and just had a lot of emotions with my mom, where she asked if I was ever going to move back. And, being their only child, that's kind of difficult. So my husband and I made a long thought out decision, and we'll be relocating. And my last day with the ACH will be April 3rd. And I just want to say to the board and to everybody I've gotten to work with, it's been such a pleasure and such an honor. I'll be working at Kaiser Permanente at the Southeastern Permanente Medical Group as a practice management consultant. And when I told Sam, she was like, I bet you answered every question the best you could. And I was like, I did, because I was so well trained. So thank you so much for the opportunity.
Congratulations. I know that Kaiser Permanente in Atlanta probably only has 3 or 4 employees, but I know a guy down there. I don't know what the hell he does, but I know him from college, so he's probably a little bit older. So I'm not going to have to listen to you give me a hard time about the Florida-Georgia game anymore?
I'll still email you. What do you mean? I will send you an email when we beat you this coming October. What do you mean?
Yeah. Okay. I'll look forward to your
Brian,
email.
when I hired Jenna, I put, you have to be a University of Tennessee fan in order for her to be hired.
Oh my God.
She was like, I know, right?
SEC Central. So, well, Jana, congratulations. I think that's good, right? You get to go home and be with your family. I mean, my parents, my family doesn't have to worry about that with me, because, I'm about as far away as I can get, and always get farther away. But no, that's good. Congratulations. I know you'll love it.
Thank you. No, I do. Thank you.
Jenna. There's a follow-up with Sam regarding Jenna's leaving.
Mm-hmm.
Sam?
Yes. And we also have another candidate, and that we're already, I just want to, before I present, she'll be at the next board meeting, but well, she'll be coming on within a month, but I don't want to reveal her name and everything yet until we've got all the papers and contracts signed, but we already have a person that's going to be a perfect fit, also coming from Lords, and phenomenal person.
Seriously?
So yes, and she's the director, or she's the supervisor of the urgent care. So we feel bad for Lords at this time, but we're so just fortunate to have Laurel, and her name is Brittany, but we won't reveal her whole name yet. But yes, we're very fortunate to have new employees coming on board that are exceptional.
Okay, very good. And again, thank you very much, Jenna. It's always been my pleasure working with you, and I know I can speak for everybody else on that same front.
Thank
All
you
right.
so much. That means a lot.
You're welcome. So let's jump into the financial reports. Becky?
Okay. Wait for them to get up. So as you guys remember, last month we talked a lot about some things that got put into our QuickBooks from our 2018 audit that we were a little surprised by, and so we did not pass the financials last month. But since then, we have had several conversations with our new auditor, Clifton Larson Allen, and we have now a better understanding of what Moss Adams did and why they did it. And so at our finance committee meeting this week, we went over everything that we've learned from Clifton Larson Allen with our finance committee about specifically about the portal money that got put onto our financials. And so what's going to happen is you're going to see that $25 million from the portal on our financials from now on. But you will also see quarterly, we are going to do a journal entry to expense against that dollar amount. So you'll see a decrease in it. It will go down. So you will get to see more of actuals on that, which we hadn't been reporting to you guys before. So there you go. You can see that the WAFE portal money that was put into our book. So the reason that they did that is because in last year, all of the ACHs got together with their auditors and decided to start recognizing the revenue that the ACHs were earning for the district money. And so our 2018 audit reflected that. And so we need to now start showing it on our financials as revenue, or as revenue in our current assets account. So there it is. It's going to stay there. If you guys have any questions about it, I'm happy to answer them. Brian or Carol or Rachel, if you guys have anything more to add from the finance committee meeting and what we learned from Clifton Larson Allen, please chime in.
No, I do not. For what it's worth, Rhonda and I attended the finance committee the other day with Becky. I thought Becky did a nice job explaining it. These are generally accepted accounting principles, and there was a desire and a need to ensure that our financial statements were falling in line with the generally accepted accounting principles. One of the things that was creating this stuff was our conversion from a cash basis to an accrual basis, and it was beginning to create some of these anomalies. So bringing this stuff forward in the manner that it's presented is as a result of that transition of a couple of months ago. You guys may remember we did that in the prior year. So I am fully comfortable with these documents. I know that Treasurer Julie. I know that Julie has reviewed this stuff too and is up to speed with it. So I am happy to make a recommendation to the board to accept a motion to accept at least that part of the presentation and the February financial statements, or the which financial statements did we pass on? The January ones?
January, yes.
Yes.
So we need January and February approved.
All right, so let's approve January 1st if we can have a motion to do so.
This is Rhonda.
This is Sandra, I'll move.
Okay, so I heard from Rhonda, a motion to approve the January financials. Is there a second?
I second it,
Sandra,
Ronnie
I'll
Batchelor.
second.
Okay, Ronnie. Sandra, we'll give you the next one.
Sure,
So,
whatever.
Motion made by Rhonda, second by Ronnie to approve the January financial statements. All in favor, please say aye.
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 Any opposed? Okay, so that motion carries. So, Becky, if you'll move into the February financials.
Okay, so what we were actually looking at was the February financials. But, so as far as the board presentation, normally what we go over with you guys is the budget versus actuals document. So if you could pull that up, please, Lauren.
Can you see it, Becky?
You make it a little bit larger. Keep going.
Yeah, I can pull it up myself. Maybe that'd be better. Little laptop screen's hard to see. Okay, so budget versus actuals. So we have our Yakima Nation Lynn. We made a payment to them, so that was exciting. Got that contract signed, and then the Merit Group funding, also our other restricted revenue up there. We, as Carol reported on earlier, we gave that $10,000 to that group that she spoke about in the report earlier, so we won't talk about that again. And then our design funds, you can see on there our budget and how much we've expensed, just over 11% of our design funding for 2020. Going down to our investments. Oh, thank you, Lauren. Going down to our investments, we have a little over $18,000 in interest earned so far this year. And then moving down into our expenses. So everything is pretty much on track for where we should be at this time during the year. The only thing I really wanted to talk about on here, unless someone has any other questions, is the LIN networks. We still have some 2019 payments that we're making out of the operations money, so that's why it's already at 72%, because we still haven't finished making those payments, but we will. And then the LIN payments from going forward for 2020 contracts will be paid out of the district money, so we won't see that on here anymore. We have our designated funds on there for our summits, our learning collaboratives, and the internships, which also will start getting paid out this year. So those are all exciting stuff. Are there any questions about the February?
No questions. So, Rhonda, any thoughts? Having you and I were the members on the finance committee, did you see any comments to Becky's presentation today?
Nope, not at all. I thought it was there was nothing outstanding or unusual. It's all outstanding. There was nothing unusual.
Thank you, Rhonda.
I concur. So I would look for a recommendation to accept the February financial statements as written.
I would make a motion to accept the February financials.
Second.
Okay, there you go. So that's Sandra.
I'm just keeping quiet now, Brian.
Okay. So we have a motion by Rhonda and a second by Luann to accept the financial statements as written. All those in favor?
Aye.
Aye.
Any opposed? Okay, this motion carries unanimously. Thank you very much. Becky, I see you on here again to speak of the teleworking policy.
Yes, so I think this is my last one. But yeah, that's so the teleworking policy that we had in our handbook before. I revised it with Carol's guidance, and the one before said that the employees had to get permission from the executive director. There was a form that they had to fill out. It was kind of cumbersome, and so we changed it to be a little simpler for the employees to telework, to make it a little more inviting for them, not just because of what's happening now, but for the future also. So we changed it so that the employee only needs to have their supervisor approve. They don't have to fill out the form anymore. They do have to report on their time card that they were teleworking that day, and a little bit about what they did. There's a memo section on our electronic time cards that we use. And then they need to do all of this electronically, so they need to submit an invoice to their supervisor, an email to their supervisor, who then approves it and CCs Carol, so that everybody in the office kind of knows what's happening and that they're working from home. So it's a little less restrictive. And then on the inclement weather policy, which we wrote last winter when we were all stuck inside with the snow, the only thing we changed on that is we added emergencies, and so we added a little bit of language about emergency declarations by local and state and national government, and that was geared towards what's happening right now. So those were the only changes that we really made. I kind of wish you could see the red line version. This was a 2-page policy, and now it's just barely 1 page. So we took a lot out, and I think it's a lot cleaner and a lot easier to read. Do you want to add anything, Carol?
Nope, you did a great job, Becky.
Thanks.
Very good. Did you? Now there were some DocuSigns that you had forwarded earlier. One was the bylaws. One was a policy. Is it this policy? Or no, it was a different policy, right?
No, it was different.
It's a conflict.
Conflict of interest policy. Okay. Would you do me a favor? And this is just me. It's not everybody else, I don't think. Would you go ahead and forward that back to me again? The
we can do that.
Policy. Thank you. All right. So do you need an approval on this? This is an action item as well?
Yes. Yes, please.
Okay. We could use a motion to accept the title policy as written. Sandra?
This is Sandra. I'll make that motion.
There you go. Now may we have a second?
Second, Kendra.
Kendra, second. So a motion by Sandra, second by Kendra. Do we have any additional discussion to have on this particular matter?
This is Kat from CHPW, and it's not to change it. I just wanted to make a comment that something that we've been discussing here at CHPW is, as we're considering teleworking policies, the ability for flexibility, that as we also are facing childcare challenges at the same time as telework and schools might be closed at the same time. So just, I don't think it needs to be included in the language. I just wanted to elevate that so that as you guys are considering and working with your managers, that flexibility is present, so that can be worked in. But wanted to note that. Thanks.
Very good, thank you. Maybe that's a practice behind the policy. Okay, thank you very much. So we have again a motion on the table. Are we ready? Is there any more discussion to have? Hearing none, perhaps we can ask all those in favor of the approval of this policy as it's written.
Aye.
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 Are there any?
Aye.
Okay. Are there any opposed? Hearing none, this motion carries as well. Congratulations and thank you, Becky. Next item is behavioral health internship, the SBAR and the analysis. This is Dan, Wes, and Diane.
Wes and Diane, go ahead and take it away.
Diane, do you want to go to the
Hey, Brian, before we start, I just wanted to note that I'll be abstaining on this topic due to conflict of interest.
Okay, thank you very much. Please let the record reflect that.
This is
Rhonda,
Dana. I
too.
also will be abstaining.
So you've got Rhonda and Sandra and who's the other?
Dana?
Okay, very good. Thank you, Dana.
This is Ronnie Batchelor. I think that I have to do the same.
Very good. So that's 4 abstentions.
I think we need to be cautious of how many abstentions.
Right. You got 4 abstentions of 9 people, right?
I do too, I think. Kendra, right?
Okay. Why don't we present this, and is it something that has to be moved today?
Yeah.
Yeah.
So let's go ahead and have the conversation.
Okay, so I'll start out with the SBAR, and then I'll let Wes kind of talk about the analysis part, and then Dan can collaborate it. So the first thing I want to bring up is that, so we're initially put $490,000 into the scholarship for behavioral health internship, and so they're also, and you'll also know, and that was coming out of the phase 2 dollars for the behavioral health incentive funding. And you'll see in the background the budget that we had set aside. We had set aside $360,000 for the Health Commons, for the Opioid Resource Network to have a Health Commons. Well, the Opioid Resource Network felt that this was too cumbersome of an amount because they would have to pay for the maintenance of it. So none of them have adopted this as an option. So we are coming to the board and asking for a reallocation of that $360,000 to be put into the behavioral health internship and scholarship fund. And so that would bring the scholarship fund up to $800,000. Because we did receive 22 applications for funding that came to $1.7 million, and so we really felt as a team that we could fund more scholarship funds if we were to allocate more funding to this. So you'll see here in this SBAR, it kind of explains the process in that we went about. As a workforce committee, we set some guiding principles as we were scoring the applications. And the guiding principles were to fully or partially fund as many behavioral health preceptor programs as possible, prioritize behavioral health positions as are identified in high need, and then also strive for geographic equity. And then we also were prioritizing that bidirectional integration and interprofessional. And so, like I said, we received 28 applications, and that was spanned across 7 of the 9 counties in our ACH. So we felt that was really great because the other 2 counties did not apply for any funding. And we also wanted to note that would be, we had 54 interns that were the behavioral health providers were asking to fund. So we did score the applications, and they all pretty much, you can see here with the scoring, they all pretty much scored pretty high. And I think that everybody presented good applications. They filled them out correctly. We do want to note that there are four of our high applications. Yakima Neighborhood Health scored the highest, and then Community Health of Central Washington and Yakima Valley Farm Workers Clinic and Lord's Counseling Center. They had exceptional applications, and we really felt that they deserved a little bit more funding than. So I'll let Wes describe how we did the analysis on the funding part take place. But so I'll let Wes go ahead and talk about the analysis.
Okay.
So very briefly, the funding included 3 components. The first component was based upon, and there's a lot of background that went into this. We had to examine the expense budgets that were submitted. We chose to examine the expense budgets that were submitted with each application to come up with an idea of how many resources were being allocated to the internships, such as intern stipends, to the preceptor costs in terms of salaries and to other costs. So that's just some informative information for the board. The funding formula itself is really based on 3 components: the number of interns within the program, and on the bottom left of this spreadsheet, if you scroll the way down, Lauren, there's a little calculator that has a multiplier. Go left and scroll way down, that's okay. So you can see there in the bottom left, there's a little table, and there's a multiplier for the number of interns. There's a multiplier for the intensity or the weight of the preceptor program itself. And there's also a bonus tied to, as Diane was talking about, exemplary applications submitted. So, for example, if an organization was precepting only SUD ET interns, they receive an intensity level of 1, which equaled $20,000. If they precepted individuals who had bachelor's, master's, doctoral, or postdoctoral trainees or interns, they received twice that intensity and twice the amount of money. So let's just pick a fictitious organization that had 3 interns. So 3 interns times the intern multiplier 4540 is the total intern contribution. If they have the preceptor weight of 2 because they're precepting master's level, they would get $40,000. And if they were an exemplary application, they received the exemplary bonus of $5,400. So based on how they rated with each one of those criteria, determined the score. However, we put a ceiling on what they submitted an application for. So if the total funding went beyond the application request, we defaulted to the application request. So using that methodology, now if you could scroll over to the right, using that methodology, can you magnify that? And to the right again. Thank you, Lauren. You can see if we use that methodology in total, it all up, it equals $849,810. With the allocation, the redirection and reallocation we're asking for today, we'll have $850,000. So we'll come within $190,000. Excuse me, $190 of meeting that amount. We think this is a fair allocation methodology that rewards components that are tied to the policy proposal. Rather than splitting the funding for organizations that are requesting a lot, we also propose that we submit the fund in one lump sum.
Okay.
Carol, did I miss that?
No, you did a great job.
And I want to point out too that we did bring this to the budget, to the finance committee
Yes.
as well. So they could be aware of it, and they also agreed with this funding methodology.
Right. That was actually what I was about to say, was that I reviewed this in the finance committee last week, and we went into it in the same level of depth. I reviewed it. We had our team look at it and felt pretty good about advancing it to the board as a recommendation from the finance committee. So we need to at least get a motion on the table so we can talk about it, right?
Brian, before you go on, Dan, I'm wondering if you want to provide some commentary as you've been part of this process all along.
Yeah, thanks, Wes. Appreciate that. So I think we have to go back to the guiding principles. If you could just highlight those again, and as the workforce committee addressed this issue and evaluated the needs and demand across the region, and one of the kind of, in addition to these guiding principles, one of the other kind of core values that we operated from was we really wanted industry partners, behavioral health organizations, to really develop a stake, and I should say, broad-based community health organizations as well. Any organizations that's providing behavioral health services. This was really an opportunity to create a stake in solving or addressing the workforce challenge, and I was very impressed with the breadth and depth of the applications, and when you apply kind of the innovation that was provided as part of each one of these applications to the guiding principles, it really it was inspirational to read through these applications and then to integrate them with the guiding principles. So we wanted to fund as much as we possibly could. And of course, as stated here, we really wanted to emphasize and prioritize what was truly our demand. And I think we've done a great job of creating and looking at geographic equity, especially in regards to how these applications were addressing social determinants of health. Really also paid attention and gave quite a bit of merit to bidirectional and integration and interprofessional practice. And we also looked and we added this guiding principle to indications that this was really an opportunity to grow programs and to broaden their reach. And I will be summarizing this whole activity of our workforce committee and our ACH staff and providing this actually to the state level as soon as we act on it. And there's a lot of people, again, that are really paying attention to what we're doing. But again, I guess I just have to give credit to the organizations who responded to this RFP and the innovation and the good work that they provided with providing these proposals.
Okay. Very good, Dan. Thank you for that. I'll also note that by the time it got to the finance committee, this proposal had already been fully vetted through the workforce committee as well. So we're probably this one's come all the way up from the leadership council committees. So with all that said, may I get a motion from the room to proceed with this.
This is Luann. I move approval as presented.
Okay, thank you, Luann. Do we have a second? Among those of us who have not seen, who do we have left?
I mean, I'd be happy to provide a second if I can, but
yes, and
okay, I'll definitely provide a second then.
Okay, so we have a motion from Luann and a second from Dan to go ahead and accept this proposal to reallocate dollars to the what are we doing? Reallocating dollars to the behavioral health internship. Are there any other conversations, discussions to have on this matter among the group? Okay. Hearing none, I would ask All those in favor of advancing this proposal, please signify by saying aye. Aye?
Aye.
Okay. Any opposed?
You
Please
need a
let the
list of names for the minutes.
I'll do that right now. Please let the record reflect that Ronnie and Sandra and Rhonda and Dana have all abstained from voting on this proposal. Is that correct?
And Kendra.
And
Kendra, okay. That's fine. All right. I think that completes that piece. Thank you very much. Next one, shared community-based care coordination vision. This is Carol.
Yeah, and Brian, just to go back on that question about abstentions, we heard from Dan Vizzini that the interpretation of Robert's rules regarding abstention is that it does not count as a vote, but the person abstaining does count towards establishing a quorum. So right. I think we're good to go.
You are good to go. You have the folks in the room will, or the people on the call will establish the quorum, and we should be able to go forward. I agree with you.
Thank
okay.
You.
Yep.
So this next item is a piece of work that the joint ACHs have been working on. We come together on a monthly basis. We've been working on a shared definition for community-based care coordination, and the consultants have wanted all of the ACHs to shop this to their stakeholders. I chose to bring it to the board of directors since I think we have a board that accurately reflects kind of the overall spectrum of services in our community around care coordination. I also shopped it within our own GCACH staff, and the comments that are in red on the screen are comments that were generated internally. And I think the biggest difference that we have here at Greater Columbia is that we are very medically home-centered. We are using the patient-centered medical home model of care, and truly believe that primary care is in the center of the universe, and that there are a lot of care coordination activities that come out of a primary care medical home. That is very absent in this definition, and so we are suggesting that we insert this to take it back to the larger group, because it's a foundational piece of what we do at Greater Columbia is coordinating care in and through our medical providers who also work with the community, but we just felt it's really important to be stated up in this document.
Okay.
The next thing is, so the shared vision would read, every person in the state of Washington has a medical home and receives the community-based care coordination support they need, regardless of insurance status, to make improvements to their health. That was another suggested addition to this community-based care coordination vision. So you can read the bullets for a statewide system for a community-based care coordination that's community-based, seamless and flexible, crosses geographic boundaries, but allowing for local control, balances community-based care coordination with any existing medical care coordination, utilizing the skills and experience of community health workers and peers with lived experience, meaningfully engages the person being served, reduces burdens on individual, clinical, and community providers, and has a secure, sustainable funding source. Then it kind of goes through a definition of what they came up with. I offered a second definition that's a little bit later on in this document. This is actually taken from Stratus Health. Again, this is probably due to my, my need to talk about that community-based care coordination is a partnership among healthcare professionals, clinics and hospitals, specialists, pharmacists, mental health professionals, community services, and the other resources working together to provide patient-centered coordinated care. So we could adopt ours, or we could adopt the cross ACH definition. And then further down, again, some of the comments that we got around the essential components of community-based care coordination is not only is it implemented across condition services and settings but it's monitored and it's evaluated because we don't want to get into community-based care coordination that doesn't have any parameters or evaluation. I'm going to address the social determinants of health along with physical, behavioral, and oral health needs. So we note for Greater Columbia, we are not addressing oral health as a project area. However, we encourage oral assessments, fluoride treatments, and dental referrals. The essential component would leverage community-based workers and peer supports, which we added. It bridges historically siloed community and clinical resources. It provides a continuum of care for individuals and families through referrals, follow-up communication, and collaboration. It transforms care delivery from episodic to patient-centered and community-based health and wellness focus, including management through transitions of care. It utilizes a system of standardized processes that identify, define, and resolve coordination needs for individuals along the care continuum. And that an essential component is not only do we actively manage health conditions through patient education, but also provider engagement and education. So that was an addition that we added to this definition. And then finally, when it talks about funding, the position paper stated that CBCC should have secure, sustainable funding, as it is an essential component to achieving success on any health outcome target. We thought it should be tied to a reimbursement model or a reimbursement system. Just to be very clear that we just don't want to have some kind of funding non-existent or to be varied from year to year. If it is tied to some kind of a reimbursement system, then it is more sustainable. And then finally, the ACHs would design the CBCC model in partnership with state health plans, clinical and community providers, and systems, county and local government. So this position paper is really the work of all of the ACHs. We just had a few additions from our point of view as a very patient-centered, medical home-focused Greater Columbia ACH.
Okay. What is it that, so you need this is a draft document. Are you looking for the board to recommend approval to advance it back to the ACH coalition, or just to identify that as our statement, our white paper statement?
Yeah, I think, Brian, there's a couple of things. I want to feel confident when I take this paper back to my other ACH executives that, and this is why we want the board to discuss it. You either believe that it should be, there should be a medical home involved in community-based care coordination or not. Right now, I'm kind of on the outside of this community-based care coordination effort because we are so strongly driven by a PCMH model. We think it's the right model, but I think it needs to be clearly identified in the vision for community-based care coordination. It would just give me a little bit of confidence that I'm speaking on behalf of my board of directors. That always lends a little bit more weight when you make arguments at that level.
Sure, I think that I'm gonna editorialize. I think you probably have that from this board. We've made that commitment to our GCACH staff as that is our preferred model of how to create the community-based care coordination. I don't know though that perhaps better, what do they call it? Better for Health or whatever group that is. They may not necessarily espouse to the same degree of intensity that we do. That PCMH model is the one. I think we're probably going to need a little bit of flexibility, but I think you can certainly advance the position of the ACH board as a medical home or medical home like entity as the center of the community-based care coordination. Is that, and again, I'm kind of speaking on my own, sort of recognizing what we as a board have said with regard to the GCACH. I don't think that we were ever speaking on behalf of all ACHs, though. That would be our recommendation that this is the right model. Regardless of what the other ones say, this is the right model for us.
Okay.
Is that a fair statement, wouldn't you think?
I think it's fair. I just, I know that there's been a lot of talk about, social determinants of health and community-based care coordination. The Pathways Hub, as you know, we chose not to move forward with that community-based care coordination model. And actually I think that there are several ACHs that are pulling away from that. So I don't think we're alone in thinking that a medical home is a good idea, but I just didn't want it to get lost in the vision.
Right. Okay. So again, please tell me, just so that I can clarify, or we can help, you and I can help clarify the ask of our board today. What is it that we are asking of the board today?
I'm asking if anybody objects to this language that GCACH staff has inserted in red, so that I can take it back to our team, our executive team.
Okay. How would you like that motion to look, Carol?
That the board of directors support the additional language is drafted in red in the CBCC vision document.
Okay. I'm comfortable with that. Would anybody on our board like to make that motion on Carol's behalf?
I so motion. This is Ronnie Batchelor.
Okay, thank you, Ronnie. So is there a second?
Yeah, I'll second that.
Excellent. So we have a motion.
Question.
Yeah.
Well, I'm curious, and I'm wondering. I think just for the sake of a broader conversation, it might be interesting to hear from Carol at some point in time, not today, obviously, to kind of understand areas of tension or pain points in this conversation and understand with clarity some of the differences. I don't know that we have good I'm definitely willing to support this request, but I think it might be educational and informative to clarify those differences. It would certainly help me out with my work.
Okay. I think that's reasonable. Carol, do you think you guys have a meeting you have a meeting in the next month on this matter, do you not?
Yeah, we just met yesterday, so we won't be meeting again until next month.
Okay. So perhaps next month, just sort of on a very broad scale or high level, perhaps you could kind of share what the other thoughts are that you're seeing in the other ACHs. There's probably only about 2 or 3 different models, I would guess, right?
Right.
Okay. So we have a motion.
Brian,
Go ahead.
before we have a motion, Kat, are you still on the line?
Yes, I'm still here.
So Kat and Jorge probably have the widest lens to view this addition or this change to. And Kat, I was just, I know you can't speak for all of the MCOs necessarily, but do you think that this is an okay addition to a community-based care coordination vision for the state?
I think it's an appropriate addition in that it incorporates the provider as a central sort of quarterback component to the work of community-based care coordination, which I know has been something that the GCACH has promoted and supported and encouraged through the work that you all are moving forward. I think I would, again, we as an MCO didn't caucus around this topical area, and so I'm going to have to abstain from any vote, but I think that it's helpful to have an awareness. I think it's helpful for the board to understand that these conversations are happening at the state, at the state ACH director level, to hopefully move the conversation forward in collaboration across at the HCA level, at the ACH and provider, and then the managed care level, because I think, unfortunately, that conversation has been, delayed for a while, and perhaps may be continued to be delayed because of what we're facing right now. But so I think from the perspective of the Greater Columbia ACH, I think it's appropriate to have that be reflected. And I think, I would agree that I think the primary care, quarterback component is something that is important to elevate. I hope that's helpful.
Thank you, Kat. That's really helpful.
Okay. All right. So we have a motion on the table from Ronnie, right, and a second from Dan. A little bit of conversation. Do we have any additional conversation to prior to having voting on this matter? Okay. So I guess what we need to do is advance the question to the board. Do you feel comfortable advancing the materials presented in this document for Carol to shepherd onto the executive committee of the ACHs as they're written, as Carol had presented a little while ago? All those in favor?
Sorry, as amended by Carol, right? I mean, it's adjusted by Carol.
Correct. As amended by Carol. Yes.
All right.
So,
thank you.
All those in favor, please.
Aye.
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 Okay. Any opposed?
This is Kat with an extension.
Okay, and Kat has an extension. So, extension, not an extension, an abstention. Okay, not. So, that motion carries. Thank you very much, Carol.
Thank you.
Next item here is the levels of engagement across ACH HIT framework. Carol and Wes.
Again, this is the result of work that the ACHs are doing at the state level to try to come to some general agreement on an HIT framework and action plan and what it might look like. And so I kind of handed this over to Wes. He manages the data management and information exchange committee, the DMP committee. He's kind of our data guy. So I asked him to take the lead on this.
Okay. Wes?
So I haven't been part of the Artemis Cross ACH Collaborative as that's been for directors, but they've met, and it's good that this topic follows on the community-based care coordination model because it's meant to support that from the HIT framework. As the executives have come together, they've had some collective interests relating to HIT that's focused on sharing information and coordination of services among healthcare and community service providers, care management and access to care plans, notification of healthcare, closing the loop on referrals, and better coordination of EM paramedical services with physical and behavioral health. So those were some of the general interests. It went into some specifics, but in the end, it led to an ACH vision for HIT, which I'll read here really quickly. And that vision is better engage people, organizations, and community partners in the circumstances, health events, and care system encounters to enable whole person care in a traditionally disconnected care settings and service through the use of HIT. So that's kind of a bit of a jargon vision, but it corroborates what I just described before then. So that HIT vision led into a strategy document that had 3 overarching goals, and under each goal are some recommendations, and there's a total of 8 recommendations under those 3 goals. So I don't know if we want to read through this or how we want to do it, but we put together a document that had the goals and the recommendations. The structure of the goals and recommendations were articulated to our DIMHE committee, our Data Management and Health Information Exchange Committee, 2 weeks ago today, by Rim Cawthorn. And Rim talked about the strategy, talked about the goals, the recommendations, and gave an outline of the action plan. And the DIMHE committee responded favorably to that and supportive of those goals and recommendations. So we took those back and internally created this document that specifically articulates the goals and recommendations, and then we came up with responses. So this is I think a 6-page document, and rather than reading through the whole thing, it's here for your review. Can I see the mouse just for a second? The Cross ACH Collaborative and Artemis Consulting came up with a work plan, and part of that work plan included some deliverables, which I'm going to open up right now. Hang on just for a second. So the deliverables for March for the ACHs, this is an actual page out of the framework document. Activity 1, discuss the HIT strategy with the ACHs, direct stakeholders within its community, determine how it fits with the current priorities and roadmap for the ACH, and determine if items in the HIT strategy should be added to the community or ACH plan. So we had that discussion with the DIMHE committee. They recommended the goals and recommendations. Again, that happened 2 weeks ago. Action item 2 or activity 2 would be to have determine the ACH's level of engagement. And back in that other document, under each one of our responses, we've indicated our level of engagement and described that. And that level of engagement comes from a list that's provided by Artemis for levels of engagement. So again, we described what we're doing. We described what we were doing, and then again connected it to the level of engagement based on this framework.
Okay.
Activity 3: identify for every goal and recommendation what each ACH may have already accomplished and identify bright spots. And again, that goes back to that same response document that we put together. And they've asked for a turnaround by the end of this month. So that's why we went through that process. And before we put it forward, and I know this is a short turnaround, not having read that 6-page document, but it articulates things such as the practice transformation work. It talks about the health commons. You know, we have mixed feelings about the health commons. It's expensive. It does accomplish some goals, but in the long term, ultimately, we want the patient-centered medical home to be the coordinator of care and to facilitate this care-based coordination strategy that will, you know, overtake things like the health commons should that eventually happen.
Okay. Okay.
So here's the document.
Go ahead, please.
I'm sorry. So here's the document. Again, unless you really want me to, I'm not going to read through each one of our responses as it goes on for 6 pages, but I'll stop here and see if you have any questions.
Okay. Do you, you know, clearly you all have, this is essentially a representation of that work which you have already done and what your goals are to move forward and tie that engagement back to what our, you know, what our overarching efforts have been, correct?
You know, for the most part, you know, given what Carol's modifications are to the CBCC, which we are all here internally supportive of, there's, I have to say, a little bit of Carol, you can help me here, disalignment in terms of the HIT framework, which again they talk about community information exchanges and things that might take the patient-centered medical home out of that care coordination role. And I think we're a little leery about those. Ultimately, we want, again, the primary care or the behavioral health care in some circumstances to have that ultimate accountability over that patient's care, whether or not they're delivering it or someone else is delivering it. Someone has to be, the buck has to stop with somebody. So in this document here, where they call out sharing that care coordination accountability, at least I do, I have a little bit of leeriness, but that said, we have become very good at responding to reporting requests, similar to the SAR, and we want to do diligence by what's being asked of us here. So we've come up with some very thorough, thoughtful responses that we think meet these requirements.
And it doesn't commit us in the future for any HIT investments jointly that the executives might want to make. This is just, these are more for information that we are working for on an HIT framework and action plan as across all of the ACHs.
Okay. Is it your recommendation that you would advance this thing, or that you would ask the board to advance this thing as it's written?
Yes.
Yes.
Please.
Okay. So I would entertain a motion to that effect from the floor.
This is Sandra. I'll motion.
Very good. Thank you, Sandra. And do we have a second?
This is Ronnie.
Yeah.
I second.
Okay. So we have a motion from Sandra and a second from Ronnie to advance the response to the level of engagement across ACH HIT framework presentation as prepared by the ACH leadership. Do we have any more discussion on this matter among the board members? Okay, hearing none, I would ask for all of those in favor to so signify by saying aye.
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 Do we have any opposed? Okay, this motion carries too. Thank you very much, and congratulations, you guys. I know that kind of work is a pain in the neck. Being careful what you write in your GCACH responses. Thank you for that. I know, because I have to write them sometimes too. It's always good to be careful what you say. All right. Thank you. That is the list of the action items this afternoon. So we've got a discussion item here. ACH numbers and stories, Carol and Chelsea.
We are going to take this off the table and come back to it next month.
Okay, very good. I appreciate you doing that. Ladies and gentlemen, I appreciate you taking the time doing this thing over the phone. It actually works pretty well. We've been able to create a little bit of time for the rest of your day, given the nastiness that we are all dealing with. I hope you are able to continue to take care of your communities and continue to take care of your families and continue to stay safe at home. We will do everything that we can to do the same. Again, thank you again for your time this afternoon. Are there any other matters to come before the board today? Hearing none, I would move for an adjournment.
So moved.
Very good. Thank you again. We will see you all.
Thank you, Brian.
Thank you, everyone.
We will see you all next week or next month. And if we need to be on the phone, we'll be on the phone. Have a great rest of your week. Thank you.
Thank you.
Thank you. Hey, Wes, are you still on?
Yes.
Wes, are you still on? This is Ronnie.
Ronnie?
Yeah, Wes. I'm sorry. I wanted to catch you before you signed off. Just to let you guys know, I was contacted by TCCH, the board chair, for bringing me on. They unanimously voted me in.
Yay! Congratulations. You will have great insights to offer them for sure. Through all
Yes.
your life experience, current work.
I really appreciate. Thank you. I'm excited about it.
Awesome. Congratulations, Ronnie.
All right, we'll talk soon. You guys take care of yourselves. Be safe.
And be healthy.
I am.